Hello, everybody. My name is Jens Chapman, and welcome from our group in Seattle at the Interesting Case Spine Discussion Series on May 23rd, 2023. I'm co-hosting with my colleague and dear friend, Scott Blumenthal from Dallas, Texas. Hello, Scott.
Hey, Jens. How are you today?
You just got muted, Dr. Chapman.
Well, we expect Jens back any second now when he figures out that he's muted. Well, maybe if he
I'm putzing around. No, I'm alive. Okay, I apologize. It's a particular pleasure to have Dr. Chris Holland from Carolina Neurosurgery and Spine there. It's a fantastic previous contributor. And he has also Dr. Michael Bohl on. And I'm so grateful that they selected a topic that is so common and from which we know so little, actually. And that's the spondylolysis of the pars repair issue. And that little piece of bone can sure be a major, major problem for us. So thank you for taking this topic and look forward to your presentation. Scott, any other intro?
No, fantastic. Looking forward to it. And I think we'll have great participation tonight. All right, you guys are on.
Dr. Holland. It's all you, Dr. Holland.
Perfect. Well, thank you very much. Let me just go ahead and share my screen here. And we'll get started. Dr. Bohl is on as well. I will start us off with a little bit of a discussion about lumbosacral osteolysis and then show a case example of a complex reconstruction that Dr. Bohl and I did together. And then Dr. Bohl will share a couple of cases depending on how much time we have as well. And hopefully, we're excited to stimulate some discussion here. Certainly a complex topic and a lot of interesting data out there. And these are some of the most difficult cases for reconstruction, particularly when they occur at the lumbosacral junction. So the osteoclastic and osteoblastic cascades are complex. There are a lot of factors involved. And these are inflammatory pathways. And so really, when we're thinking about bone in general, we always think about this balance between osteoclastic and osteoblastic activity. And this is really thought to underlie the osteolytic processes in the spine, where that balance is pushed in one direction or another. And so it's thought that there's an inflammatory component to both bone growth and development, as well as an inflammatory driver of osteoclastic activity and osteolysis. And certainly we don't fully understand why why and how that cascade can be pushed in one direction or the other. When we think about osteolysis, there are lots of different mechanisms, some of which have been proven and some are theoretical. Certainly, we know that we can see significant osteolysis in infection, but these aren't just active infections. These can be occult or indolent infections as well. Lots of neoplastic processes, both malignant and benign, can cause bony destruction. And then there's a lot of small studies or case series or even case reports of BMP use resulting in an osteolytic process in some studies early on after the application or use of BMP, and in other cases, more delayed reactions. And there are theories about end plate decortication and dosing of BMP that might derive some of those causative factors that may tilt the scale more towards bone destruction than bone formation. Some of the early theories around BMP osteolysis was that its mechanism actually led to some bone resorption before it transitioned into bone formation. And some of the studies that I've cited here below looked at cervical spine with what I consider fairly high dosing, 2.1 milligrams per level, and they saw osteolysis and end plate resorption in about 57% of the levels treated. In the lumbar spine, studies have shown, again, very high BMP dosing, up to 5 milligrams within the interbody space, and looking at end plate resorption and osteolysis in about 25% of the levels treated. In some of these reports, it was very early on, And in others, it was a delayed effect where the osteolytic processes took place months or even years later. In cervical fusion in particular, Toomey Allen put out a report of 200 patients. In that report, they had a variable dosing of the BMP. They started with 2.1 milligrams in 24 patients. They moved to approximately a milligram in 93, and then the last 83 patients were treated with around 0.7 milligrams per level. They had x-rays at 6 weeks, CT at 3 to 6 months, and they didn't show any evidence of end plate resorption or subsidence in that study. I published a study with some of the members of the same group several years later, looking at 191 consecutive patients with BMP and cervical fusions. And in this study, we were looking at both fusion rates and rates of dysphagia, but we compared BMP to beta tricalcium phosphate, but with a significantly lower dosing of BMP of about 0.5 milligram per level, with a median follow-up of 12 months. And we had demonstrated really statistically superior fusion rates with BMP, 70% at 6 months and 99% at 1 year, and did not see end plate resorption or subsidence or osteolysis. So certainly when we look at it in the lumbar spine, there are a number of, again, small studies or case reports looking at this process. You can see in these CT images here that the initial images show implants within the interbody space and subsequent development of a large osteolytic defect. These were cases with peak interbody cages and BMP. Here's another example. This is a case in a 50-year-old woman with BMP within the interbody cage. Again, this is typically higher dose BMP. So in some of these cases, they were putting 4 milligrams of BMP anteriorly in the disc space and then loading the cage with 0.5 milligram or so or less of BMP. And you can see in the early images, when the patient began to develop severe low back pain postoperatively at about just shy of 3 months, there's a significant osteolytic process taking place. And then you can see at 6 months postoperatively that there's been some osteoblastic activity, and there's now bone formation starting to fill that void and actually bridge the interbody space. In most of the reports around osteolysis of this nature, these patients require revision, often due to implant subsidence, a hardware failure, or an enlarging defect. Here's another a paper by Nottmeyer looking at not only osteolysis, but the development of subchondral cysts within the end plate in transforaminal lumbar interbody fusion with BMP. And this was just a report of 2 cases that showed the development of these subchondral cysts with expansion following the use of BMP for transforaminal lumbar interbody fusion. Some of the other proposed mechanisms, include periprosthetic metallosis, and this is not just in spine surgery, but in orthopedic total joint repair as well. And there have also been some reports of post-traumatic osteolysis. The radiographs here are from a patient that had a cervical spine trauma. The initial post-traumatic x-rays are on the far left. And then you can see that there's progressive osteolysis, collapse of the disc space, and a kyphotic defect or deformity that develops there. So what about something like cervical arthroplasty? Well, initially this was reported as a rare complication. It was, again, first described by Toomey Allen in 2011. And this was thought to be a response to submicron particulate debris, whether this be metal ions or polyethylene, and that this stimulates a chronic inflammatory response. And for reasons potentially unknown, this favors osteoclastic versus osteoblastic activity. We know, again, the inflammatory response can drive either. And what's important for our understanding of this moving forward is how can we tilt that scale to drive more osteoblastic activity in our favor when we're looking at a fusion, and how to avoid osteoclastic activity around an arthroplasty, for example, that leads to osteolysis or implant instability. When we think about the other side of that, heterotopic ossification of an arthroplasty graft, again, maybe this is a situation where there's, again, a chronic inflammatory process, again, potentially derived from particulate debris. that leads to, or metallosis that leads to an inflammatory response in a more of a osteoblastic favoring response. So lots of unknowns there. Here's some examples of that. There are radiographs where we see osteolysis around those implants following a 2-level cervical disc arthroplasty. We know that we see osteolytic activity with spondylodiscitis and osteomyelitis. This is often referred to as rare, although we feel like we see increasing frequency year over year, and it's been reported to affect as many as 2 to 24 cases per million individuals in developed countries every year. It certainly can lead to vertebral osteolysis, and those patients with neurodeficits or progressive deformity often undergo treatment. It was demonstrated by Biden et al. And others that instrumentation in these cases is safe, and there is not an increased risk of reinfection in these patients. This was a case that I saw just recently that was believed to be a spondylodiscitis. It certainly had the imaging characteristics of it with progressive deformity and vertebral body osteolysis, although this not only cultured negative, but was explored and treated surgically with no evidence of cultures, and this was thought to just be a severely degenerated disc or a Charcot type joint phenomenon. So I'd like to really spend the majority of the time here talking about this illustrative case, which really I'm going to take you through the progression of this individual and then ultimately the development of a severe case of osteolysis at the lumbosacral junction, primarily involving the L4 and L5 vertebral bodies, as well as the complex reconstruction required to treat this. Dr. Bohl also has several cases, one or several cases that we might be able to get to as well afterwards, but we'd love to stimulate some discussion here because I think this is a really important and interesting topic. There's not a lot of literature around it, and I think there are a lot of things that we still don't understand. The most challenging part is then the reconstruction, because we don't understand what the process was leading to osteolysis, and we're looking to treat this obviously surgically and obtain a solid bone fusion in a patient that for one reason or another had been predisposed to a more osteolytic pathway. So this patient was a 71-year-old male patient who had multiple prior lumbar operations beginning in 2015. His last operation prior to presenting to our practice was in 2019. And he had several complications with his surgeries, including a CSF leak with a reoperation and repair. He also had at some stages evidence of pseudoarthrosis and screw loosening that required revision. When he presented to our office, he had severe low back pain, bilateral lower extremity pain, and was essentially bedridden. Over the last several years, he had lost the ability to mobilize. He was unable to stand for more than a few seconds and was using a handheld urinal and basically was home and bedbound. He had been in extensive pain management and had tried to move away from narcotic pain medications, but was severely debilitated, was utilizing medical marijuana, and had seen several surgeons at this point who had said essentially his only option would likely be spinal cord stimulation. But I want to take you back to the beginning. We were fortunate enough to get access to all of this patient's, or a lot of this patient's imaging that take us through his surgical process. He didn't have any of these procedures with us, and we had limited access to the operative notes from the procedures, but he tended to seek evaluation in our office in between these procedures. And so we have a number of imaging studies to go through. So starting here, the patient had an MRI and some plain film upright radiographs in 2014 that showed really diffuse degenerative spondylosis, some loss of lumbar lordosis, severe disc space collapse and facet arthropathy, really diffuse degeneration there with some stenosis centrally as well as some foraminal stenosis. This was most severe at the L5-S1 segment. He had subsequent imaging in 2015 and 2016, both the MRI at left, you can see now progression to a myridine grade 1, almost grade 2 spondylolisthesis at L5-S1. severe multi-level degenerative stenosis, progressive degeneration of the intervertebral discs. He's developing some asymmetric disc collapse with a mild coronal deformity, obviously here measured on CT and more appropriately measured on weight-bearing upright films. But we see here gas within the disc spaces almost diffusely and severe multi-level degenerative disease. At that time, the patient was treated with an L5S1 PLIF with bilateral peak cages. There was some incomplete reduction of the spondylolisthesis at that level, but with some restoration of lordosis, but still with chronic proximal multi-level degeneration above this construct. While we don't have this initial operative note, all of the subsequent operative notes included the use of BMP, both within the disc space and posterolaterally at relatively higher doses. And so the presumption here was that BMP was likely used in this operation as well, although we don't know that for certain. Here, the patient was subsequently then treated with extension of fusion at L3, L4, and L4, L5, again with bilateral PLIF cages, now titanium cages. His prior instrumentation was removed and he was not re-instrumented across the L5S1 segment, which at this time was showing solid bone fusion. The patient had this operation per report, still had chronic pain issues, had possibly some short-term modest or moderate incomplete improvement. The patient had subsequent CT imaging in 2018, and here you see some haloing around the pedicle screws proximally. Oh, let me just see. I'll pause here for a second. I think we have a question, so let me stop. Dr. Blumenthal, do you have a question, or would you like me to back up?
Yeah, a couple slides back, the first operation, which was the 5-1 fusion, on the
Yes.
it looked like he had a multi-level decompression as well.
It did. So we're basically going from the films here because we didn't have any of the records for these operations. He was being treated by a surgeon just outside of our area who ultimately closed the practice and moved out of state. And so we weren't able to access those records, but I agree with you. It looks like he had a multi-level laminectomy above, at least at L3 and L4, and maybe a partial L2, in addition to the L5S1 fusion.
And
Thanks for pointing that out.
The subsequent surgery was done. The couple levels above. Did any of the records show like what they were thinking?
No. So we don't have access to any of the office notes. And with the only operative note that we'll have will be the final operation in 2019, which was an L2-3 extension of fusion, and ultimately above the prior L3 to L5 construct at that time.
Yeah, I mean, maybe Jens can comment as well, but unfortunately, we all see the end results of ill-advised surgeries or ill-performed surgeries. And you can see in the PLIF, the 2-level above PLIF, it certainly didn't improve his lordosis. In fact, made it worse.
Right.
Obviously created pseudarthroses with the loose screws. And I mean, you kind of know where this is headed.
Oh, absolutely. And when you look back through these films and you go through in order, it's very easy to predict, even from the initial images before he had his first surgery. You see the extent of what he would likely have required for a definitive operation up front, and you can almost know that he's not going to get that.
And on a further note, we just talked about that 2 weeks ago. Excuse me. When we had the Rothman Institute on, decompression above a fusion, if done like this as a midline sacrificing procedure, has a clearly statistically much higher risk. I looked up the article in question of adjacent segment deterioration, and if not done. So, and that's from the AO Spine Knowledge Forum that's published in the Spine Journal 2022. So this is really, in all regards, it's easy to harp on that badly designed and thought through in this particular patient who's clearly cursed with a pan-spondylotic lumbar spine, but in absence of clear neurology or deformity, he was clearly not given a favor with this surgical exploration.
Yeah, no, I couldn't agree more. Especially when you do this midline decompression like this, you're stripping away all of the muscle and ligamentous attachments and completely destabilizing a severely degenerated spine. I'm really not even comfortable in most cases doing a sublaminar decompression adjacent to a fusion with preservation of those attachments in somebody with severe degeneration like that. I think the likelihood of progressive instability and further degeneration is just so high. So jumping back to 2018, you can see here, in this post-op and follow-up CT, he's got lucency around the screws, really at L3 and L5, likely at L4 as well. It does not look like he's achieved a solid bone fusion at the L4-5 segment. There may be some possible bridging bone at L3-4, but it's unclear. And with the lucency around the screws, I'm concerned for pseudoarthrosis at both levels. And you can see the progressive degeneration within the disc space at L2-3 above, and gas within the disc space above that at L1, L2. So this was the operation we were able to obtain the operative note for. This was done in March of 2019, and the plan was for an L2-3 PLIF and a revision of L3 to L5. The patient intra-op was found to have loose screws at every segment, but only some of these screws were documented to be replaced. Some of the screws were just removed and reinserted, not upsized in terms of length or diameter. And some of the screws that were replaced were just placed in a new trajectory. There was documentation of a revision posterolateral fusion, and there was BMP placed within the L2, L3 disc space, as well as posterolaterally as part of that revision. So this is what this looked like in 2020. The patient had bilateral titanium cages at the proximal segments, bilateral PEEK cages at L5S1, with a extension fusion construct from L2 to L5. And at this point, he's having chronic pain, and he's now, his surgeon has left the state, and he's looking for additional care. So he gets several surgical evaluations. He's being referred to chronic pain management. People are discussing spinal cord stimulation with him. You can see what still looks like solid bone fusion at L5S1, likely still pseudoarthrosis at 4-5, and possible pseudoarthrosis at the proximal segments. So this is when he presents to our office in 2022. He had been seen in 2020 with those last films and told that there wasn't a clear indication for further surgery, and then presented to our office in 2022, where at that time, as I described before, he was in constant 10 out of 10 pain, going from his back into both legs, all the way distally into his feet. His pain was worse with standing or sitting. He really could only get mild relief with lying down and was essentially bedbound. He had a significant weakness in both legs with numerous falls. He could only mobilize very short distances with a rolling walker, and had diffuse sensory symptoms in both legs, both numbness and paresthesias. He was unable to urinate while standing, but denied frank incontinence. He was using that handheld urinal and laying down. He was on soma, Valium, gabapentin, and oxycodone. Had a history of lots of conservative treatment and multiple pain management practices. And he was on chronic warfarin for factor V Leiden, just to make things a little bit more interesting. On his physical exam, he was laying down in the room, was unable to really sit up, in pretty severe and distress, visibly uncomfortable. His incisions were well healed. He had a difficult motor exam just because he was in such severe pain, but he seemed to be at least anti-gravity in his lower extremities. He had decreased sensation in the right lower extremity and several nerve root distributions, had decreased deep tendon reflexes and no clonus. At that time, we got some upright radiographs that showed retropulsion into the canal of one of the titanium cages at L4, L5, significant lucency around the pedicle screws at L5, and subsequently obtained a CT image which confirmed the pseudoarthrosis and retropulsion, but also showed a large osteolytic defect involving the L4 and L5 vertebral bodies. Here are some more images from that CT. Again, you see that most of the ventral portion of the L5 and L4 vertebral body has disappeared, as well as this defect extending down into the L5-S1 interspace, where there does still appear to be solid bone within the peak interbody cages there, but you can see the haloing around the screws at that level. Here are some more images, again, coronal and sagittal CT images showing a severe osteolysis at the L4, L5 segment. So as part of the initial workup, this patient was using nicotine products. We made sure that he was able to stop doing that for approximately 6 weeks. We confirmed that in our patients with a urine nicotine and cotinine test. An L5 aspiration and biopsy was ordered for both aerobic, anaerobic, and fungal cultures, as well as tissue culture to rule out any neoplastic process. We wanted this patient, given his medical history, to get medical and cardiac clearance. He, for patients with type 2 diabetes like this patient, we want a hemoglobin A1C, his history of blood clots and factor V Leiden. So we needed to address his perioperative anticoagulation as well as his transition back, and obtain a DEXA bone density scan. So his bone density was okay. He had some mildly diminished density consistent with osteopenia. When he returned, he did successfully quit smoking. His urine nicotine confirmation was negative. The culture was negative. There was no aerobic, anaerobic, or fungal culture growth. We did ask for a prolonged culture to rule out any indolent organisms that did not return any positive culture. And the tissue that was sent did not demonstrate any malignancy or benign lesion. His hemoglobin A1C was consistent with decent blood glucose control. And his DEXA scan was consistent with mild osteopenia. He was able to obtain cardiac clearance, and his factor V Leiden plan was to put him on Lovenox postoperatively and then transition him back to warfarin. So the patient was, after meeting all the criteria to proceed with surgical intervention, the patient essentially said that if he couldn't have this fixed, he didn't want to continue to live the way that he was living. The decision was made to proceed with surgery with a planned lumbosacral reconstruction with spinal pelvic fixation and bilateral approach to the L4 and L5 vertebral bodies for corpectomy and anterior column support with bilateral cages. Here are a few intra-op images on the left showing after we've removed the bilateral L4, L5 cages, one of which was in the spinal canal. And at right, this is the placement of the first expandable cage within the corpectomy defect. Ventrally, there was a lot of granular tissue, no evidence of infection, pus, or purulence or phlegmon, but lots of degenerative and inflammatory material there that was scraped out, as well as removed some abnormal or partially degenerated bone. Here is the image after implanting the second cage. So a nice overlap there. You see that just increasing density within a cage as those cages are well aligned with one another. And so intraoperatively, this patient did have a history of prior CSF leak. There were 2 small intraop durotomies that were repaired primarily with 6-O-proline. We had a hemovac drain postoperatively. We felt we had a good closure with no CSF egress, but he did develop some postural headache post-op and had some higher drain output. So that was ultimately removed, and his headaches resolved with no issue with wound drainage or persistence. He had a dramatic improvement with mobilization. This was somebody that was essentially bedbound and walking with PT postoperatively. Before discharge, he was able to walk 150 feet with the physical therapist and was able to discharge home on post-op day 7 with home health physical therapy. These are his post-op images at 6 weeks. His proximal instrumentation was solid. There was no haloing there, but we did lengthen and increase the size of the screws there, as well as place new S1 pedicle screws and bilateral lumbosacral pelvic fixation there with a quad rod construct. And you can see the bilateral cages there in the L4, L5 defect. At 6 weeks, the patient had a dramatic improvement. He reported his pain as 2/10, but stated he was now having long intervals of time with 0/10 pain. He was only using pain medication sporadically when he would have an episode of pain, but was no longer consistently taking it. And there were many days at a time when he was not using any pain prescription medication at all. His wounds were well healing. He was in a TLSO brace when out of bed or ambulating. And we did give this patient a bone growth stimulator that he was using daily, just to belt and suspenders this guy, and hope that we get solid bony fusion. The patient's actually scheduled for his 3-month follow-up visit tomorrow. So in conclusion, and then I'll turn things over for further discussion, as well as to Dr. Bohl, who will share with us tonight as well. Osteolysis, particularly at the lumbosacral junction, the pathogenesis here is uncertain. It's certainly a chronic inflammatory process that's mediating this, and whether that's due to simple instability, BMP use, indolent infection, or submicron particulate debris is unclear. This patient developed his osteolysis at the level of pseudoarthrosis in a delayed fashion, several years after surgical intervention at that segment within the interbody space. The reconstruction in these cases is complex. It's challenging to get good anterior column support, and anterior approaches are quite difficult, in these patients, given the extent of inflammation in the prevertebral and retroperitoneal space. You absolutely have to rely on spinal pelvic instrumentation and multiple rod constructs. And these are always kind of creative or patient-specific solutions. And I think we'll see some of that creativity in Dr. Bohl's work as well. So I will end my screen share at this point, and I'd love to have more discussion about this case or about lumbosacral osteolysis in general. And then I'd love to turn it over to Dr. Bohl so that we can further the discussion and look at some other interesting cases.
Chris, that was a great case and really, really difficult, obviously. So you mentioned a lot of things in your introductory talk that I want to pick up on. Obviously, I think one of our commentators in the chat room has mentioned the risk of an infection with previous surgery being a significant factor in a compromised host. But you mentioned something else interesting that has intrigued me, because I've had some of these patients myself who I thought I did a really good job on. They just will not heal. And that is a Charcot arthropathy. Speaking as a neurosurgeon, is there a way that there is a neuropathic joint that we create either through surgical dissection or in chronic opiate users or through other factors that we don't quite fully understand? Because what I'm seeing there is something that really looks like either an infected joint or a neuropathic joint. So what are your thoughts on a neuropathic etiology of this?
Yeah, I think that's a great point. I think, really we just don't know. My initial presumption in this patient who had had so many surgeries was that there was an indolent infection there, and that this was an infectious inflammatory process. And so that's why we went directly to the biopsy and cultures up front to see if we could assess what that was. And we'd have a plan in place to treat that aggressively as we develop the surgical solution. We see a number of these patients with that Charcot phenomenon, that neuropathic joint phenomenon. And whether or not that's a factor here as well, it's hard to know. And it's hard to know what we do surgically to cause that and what we could do to prevent it. I think there's a lot to be understood there. I think from our standpoint, I don't have a good answer. I think it could be, certainly could be that phenomenon. There's a question in the chat as well about whether or not we would recommend antibiotics in cases of presumed infection without growth on culture. And that's another great question. We we put this patient on perioperative antibiotics, but did not put him on a course of antibiotics following the surgery, as we didn't have any organism to treat, and we didn't put him on prophylactic or presumptive antibiotics in that case.
So a comment I would like to make, you had a short slide or two on osteolysis in cervical artificial disc, and we've been doing a lot of research on that at TBI. And interestingly enough, we found and we've been seeing referred cases in as well as some of our own. And we found a high incidence of C. acnes infections that you have to sit their cultures for 2 to 3 weeks.
Right.
Because she had negative cultures and negative fungus, doesn't mean that there couldn't have been C. acnes. Now, whether or not that's just an associated colonization, biofilm, whatever, or an active infection, and that kind of goes back to the question that was asked, on the screen. But really interesting stuff. And there's a recent paper in one of the journals, I think it was the NAS journal, on what to do with C. acnes positive in cultures in patients that really don't exhibit anything other than loose hardware pseudoarthrosis. And that answer is not out there. I mean, there's, you can do, I guess, oral doxycycline is kind of our protocol, but whether or not the surgical reconstruction is what takes care of the colonization/infection or not, we just don't know. But I know that our deformity guys and reconstruction guys at TBI are holding the culture for 2 to 3 weeks when they do revisions to look for C. acnes, as well as what we do when we do cervical arthroplasty revisions.
And how long do you continue the doxycycline for typically?
There we go.
6 weeks or?
This is like shooting from the hip.
Yeah.
6 weeks of oral doxy.
Okay.
They're not particularly, as you know, they're not particularly virulent infections.
Right.
I do think the stabilization of the reconstruction is kind of what takes care of it. But we feel like if the culture is positive, we should give them something.
Absolutely. And that was one of our concerns. That was one of the organisms we were particularly concerned with in this case as well. So it's interesting to hear that protocol, and that's maybe something that we'll adopt in these cases moving forward, is treating those patients presumptively and then extending the culture for several weeks to see if we can grow it.
For whatever it's worth, I think that question really cuts to the heart of this issue, and it is a really interesting question. This pathology, to me, presents very much like Charcot arthropathy. It's typically in patients who have some kind of severe biomechanical instability. We see this massive osteolysis, just this terrible bony and soft tissue destruction. Cultures are typically negative, and it gets better with robust stabilization. I mean, I think the question asked is cuts to the heart of it. And obviously, I don't negate the C. acnes data, but to me, this pathology acts just like all the Charcot spines that I see. You see just this massive destruction, and it gets better when you stabilize it. So I think, in my opinion, for whatever it's worth, I think that this is very similar to Charcot arthropathy. I know we typically see that in patients with severe neurological injury or disability, but these people present that way. They, for some reason, they're able to go long enough. I mean, this patient you present, Chris, is several years out from her failure, his failure. There's something, being able to maintain or tolerate that many years of that much instability and destruction at your lumbosacral joint. I think there's a strong correlation there. I think that there is something neuropathic going on here.
Yeah, and you're presenting a very severe form, albeit we've seen maybe once or twice a year, we see in just a degenerative ALIF with and like a screw cage, where the screw maybe pushes some of the BMP into the vertebral body, And at about 3 months, we see this osteolytic disc formation around the screws. And those you can kind of just ride out because it's just an osteoclastic phase that eventually will fill in with bone. Much more benign, obviously, than what you're talking about. But yeah, I mean, osteolysis has a lot of different faces.
Right.
Hey, shall we go for our next case? Dr. Vole,
Yes.
thank you for joining us.
Thank you. You guys see my screen okay there?
Yes.
All right. Well, thanks for the invitation. It's an honor to present, and this is a really interesting topic. My name is Michael Bohl. I'm an adult and pediatric spine deformity surgeon in the Carolinas there with Dr. Holland. The case I have to present today is a similar one. Sorry, one second. You guys still able to see that screen there?
Yeah, can you go to presenter mode?
I can, but when I do that, there we go. How's that? You see that?
Perfect.
Okay. So similar case of L5 osteolysis. You can see the CT scan here on the right that shows what was previously an L4-5 interbody, and then an L5-S1 interbody, and then just a bunch of dead space there. And what I, piggybacking along the conversation and questions we just had, is what I typically see in these cases. The common thread I find is severe mechanical instability, hardware failure, global spinal imbalance, spine deformity, often coming with that, neural element compression, central foraminal stenosis that is severe, and then this question of underlying infection. And what I've found is, just like in Charcot joint cases, is that typically cultures are negative. Now, whether that's because it's truly not an infection or because we're just not culturing long enough, or we're not picking up some kind of indolent infection like Thiacnes, I don't know. That's a very good question. My treatment regimen, the way I approach these, is very similar to any large adult revision spine deformity. First we deconstruct the spine before we reconstruct it. So all the old failed hardware has to come out. The neural elements need to be decompressed, and that osteolytic space needs to be resected and debrided. And then you reconstruct. You need a good anterior column support plan, and there's lots of options for that. All of them good, depending on how you use them. Deformity correction, and then most importantly, I think, is a very robust spinal fixation construct. Especially at the lumbosacral joint junction, there's tremendous biomechanical forces at play. I do think that plays a part in this pathology that we see down here, and you need to provide them with something very robust. The patient I'll present is a 68-year-old woman. She had 5 prior spine surgeries and presented with severe mechanical back pain, much better laying down, could barely tolerate standing up. When she stood up, she fell forward. Claudication, radiculopathy, all the same symptoms we typically see and would expect from this pathology. Here's her pre-op standing scoliosis films. Her SVA is over 15 centimeters. Her pelvic incidence is 65, 66 degrees. Her lumbar lordosis is 15, so about a 40-degree mismatch, and her pelvic tilt is 45 degrees. So even with tremendous effort to retrovert her pelvis, she's still 15 centimeters positive, and a little bit of coronal imbalance, a little borderline at 5 centimeters. Here's the CT scan. This is a supine CT scan, and interestingly, you can see how much mobility she has across her lumbosacral junction there. She goes from a lumbar lordosis of 15 degrees to 35 degrees just when she lays flat for a CT scan. There's also a little bit of haloing up at her proximal level at the top there, but not her primary problem. More CT scan slices. You can see on both the left and right lateral kind of slices there on the sagittal view, severe haloing around the S1 screws, and almost complete destruction of the L5 vertebral body. The L5 screws are just floating in dead space there where the body used to be. MRI shows compression centrally and in the foramina, as one would expect. So our plan was to revise this. We removed all the previously placed hardware, revised at the top. There was the screws at the top were loose, which is separate problem, not her primary problem. Once all the old hardware came out and we put new hardware in, at the top left here, you can see our new screws placed. You can see 4 iliac fixation points. I'm a big fan of 4 separate iliac fixation points with a separate rod attaching to each one of those fixation points. I think that does provide excellent spinopelvic fixation when each rod has its own pelvic fixation point. So you can see those on those intra-op views, on those teardrop views. And then I like to cement the top for long segment constructs. That's something I've been doing now for a while and do believe in the utility of. Here's her immediate post-op. Didn't have good intra-op pictures of this, but you can see there at the bottom at L5S1, the L4-5 interbody came out, and we reconstructed the bottom anteriorly with a Harms cage. You may notice there I put the Harms cage in sideways. That's something I've been doing, not just for this pathology, but for a lot of pathologies. I think it's a really nice technique to use. It provides a great fulcrum. You get great lateral distance across the dead space, and it's very nice. It creates a nice fulcrum for rotating somebody back into better sagittal balance. So this is her immediate post-op CT scan. You can see the quad rod there with each rod going to its own pelvic fixation point. Here's the CT scan. Again, Harms cage down at the bottom at L5S1, and now with a megaforamen between L4 and S1 pedicles. Neural elements all decompressed there. And this is her 3-month post-op follow-up, and she's doing really well. I ask all my patients just what percentage better or worse they feel compared to before surgery, and overall she feels 90% better. The last 10% is some back stiffness, which I think at 3 months is not unreasonable. She's doing PT now to help with that. And she reports 100% resolution of her leg pain and 100% resolution of her postural problems. She feels like she's standing up straight now. And our 3-month standing scoli films support that. Her SVA is now just over 3 centimeters. Pelvic incidence is unchanged. Lumbar lordosis is now 56 degrees, so her PILL mismatch is just about 10. She's still got a high pelvic tilt, but it's improved. And so I'm happy with this outcome for 3 months. 3 months is 3 months. 3 months isn't a year. It's not 2 years. It's not 5 years. So we'll of course see how this goes, but I'm cautiously optimistic with her. Just one quick comment. If there is a nice thing about this pathology, at least in the setting of sagittal imbalance and deformity, it's that doing a big correction at L5 is, if you're going to bring somebody back, it's the place to do it. The lines I drew here on her pre-op x-rays show the amount of focal correction one would need if you wanted to bring her back to an SVA of 0. And this is something I show our residents when we're teaching them about focal 3-column corrections of spine deformities. in order to get her back to an SVA of 0 with an upper thoracic PSO, which you would obviously never do, but that would require a 100+ degree correction. A lower thoracic would require a 43-degree correction. And if you're treating her down at L5, which is where the pathology is in this case, which is what we did, you can achieve that with a 22-degree correction. And so if there is one nice thing about this, it's that correcting people sagittally is certainly easier with a large L5 3-column resection and spine reconstruction. And then just a quick comment on these sideways harms cages. I know this, I'm certainly not the first person to do this, and I think that there are probably plenty of folks out there who use this, but I do think this is a powerful technique. I think it provides excellent, very robust anterior column support. It provides a great fulcrum. You can fill that thing with as much structural or morselized autograft and allograft as you want. And it's something that I've found to be very helpful, not only for L5 osteolysis cases, but this is a patient who had a percutaneous fixation that failed, that we reconstructed there. This is a neuromuscular, a rigid neuromuscular scoliosis case that we reconstructed with the lateral harms cage. You can see there on her post-op AP. I found it to be very, very effective. Thank you, guys. I'll open it up to any questions.
I love the cases, love the thought of lumbopelvic fixation done properly, really alleviating the stress rise at L5S1. I think this congerment of instability and neurotactic bone is really a helpful principle to understand. I've never seen the transverse cages used like this. I've done those for lumbopelvic reconstructions and oncologic cases, but I'm not sure that the harms cages that I have are strong enough to actually withstand the axial pressures of the anterior spinal column. So I thought that's pretty ingenious, but I was happy that you used quad rods in the presence of a transverse cage.
Yeah, you know, we'll see. Maybe it's a different harms cage. The ones that I've been using, they're pretty robust. I mean, I can't. I certainly can't squeeze them. Now I know my hands are not able to create the kind of force that a human body creates at L5S1, but they're pretty thick titanium. But we'll see, of course. Like I said, this patient's 3 months post-op. These other ones are all 6 months post-op, and so far no failure of those sideways harms cages. I have mentors too from training who would do these, and they were big fans of them, of the sideways harms cage. But it's just something I found to be very useful.
And you put that in from the front, right?
No, from the back.
Wow.
Yeah.
Okay. That's remarkable.
I do believe in the value of anterior and lateral surgery, but I'll be honest, the large majority of my practice has moved to open posterior. I've just found that we can get quite a bit done from the back and save people the extra stages. That's no criticism of anterior and lateral surgery. Those are very powerful approaches, but that's certainly where my own personal practice has moved to with the deformity I see is predominantly open posterior approaches. And you can get a lot, you know, especially with this kind of harms cage, you can create a lot of big anterior support from a single stage open posterior.
I'll have to go into the anatomy lab and practice that, because I'm very much a posterior person. Also, we agree in many philosophical arenas, but right now I can't. I fished out XLIF cages from the back without damaging nervets, but right now I can't conceive snaking that around. Scott, any thoughts from your end?
Hello. No, an amazing reconstruction. I mean, that looks just terrific from what you started with. Those are tough cases, and those of you guys that do these kind of revision surgeries, I'm impressed.
I think the key points for me are the significant issue of looking for the lumbosacral junction and healing. I think one of our Dr. Abdel Rahman pointed out sometimes correctly, pseudarthrosis is most common in the caudal segments, and yet somehow a lot of surgeons kind of forget about it and don't pay attention to what's osteolysis and what's a sag effect of the cages in vertebral bodies with intussusception. That's a common problem, and it might be because of how the x-rays are formatted, but the simplest test, which is a non-contrasted CT scan, is sometimes not obtained. And having a lower threshold towards looking at that critically with the CT scan, if there's recurrent pain, loss of reduction or alignment, would be definitely a good thing to do. One question I have for Dr. Bull is, do you do formal lumbopelvic fusions when you do these instrumentations? I mean, that's still an unanswered question for me in terms of avoiding the hardware failure there in the longer run. Having done those now for about 10 years, that's still a weak spot for me in certain patients.
Yeah, no, that's a great question. And there are as many different ways to do that as there are devices out there to achieve that. What I personally like to do is I prefer iliac screws, and I'll oftentimes decorticate out the dorsal aspect of the SI joint and pack that with bone as well. I don't have good data for you on how many of those, how many patients I see who fuse. But the SI joint clearly is at risk here. It's something of an adjacent level. Now we're fixating across it, but just putting iliac screws in and a rod across it's not very good SI joint fixation. And so that's a great question is about that. And there are some new products out there that certainly have some promise. I don't have a lot of personal experience with them. But some of the new S2AI screws that are 3D printed that supposedly allow bony ingrowth across the screw. It's nice to see the technology happening because people are obviously thinking about that issue. But the way I personally address it is I decorticate the PSIS of the iliac bone and decorticate the sacrum and pack that with bone as well.
I use a slightly different technique. So Michael and I operate together a fair amount, although not as much as we would like to. But I tend to prefer S2AI fixation. And what I've started doing in a lot of these native cases is doing an SI fusion as well. So packing an SI fusion graft and putting that across the SI joint in addition to the S2AI screws to try and get an open SI fusion as well, decorticating that joint with the drill and passing the SI fusion device across the joint in addition to S2AI fixation. I also don't know. I don't have great data other than anecdotal data, but I'm worried about getting a fusion across that joint, because I've had patients with spinal pelvic fixation who develop chronic SI pain, either unilateral or bilateral, and I've come back and done a MIS SI fusion and their pain's resolved. And so now I'm thinking more about that up front while I'm doing those fusions in the index operation.
How do you address it, Dr. Chapman?
I know we're reaching the end of the hour, but
we got to get out of here. So yeah,
Dennis said, diagnostically, unenhanced CT scan is the absolute diagnostic of choice for osteolysis. And it's kind of underplayed it, but it's absolutely a pearl that you need to take home from tonight.
Absolutely.
Great presentation from our Carolinas friends. Thank you so much for talking about osteolysis and paying great attention to this significant detail. And I was very glad, speaking as an orthopedic surgeon, that you showed that bone cells are smart. They have feelings. They are calcium channel messages needs to be